This is just a recording on extensive recording for your health assessment. This is a detailed version. Later I'll be also uploading a video on how you will do your physical assessment with the abdomen. So let us just review the subjective data first. So is there abdominal pain present? If ever there is, you go to your cold spa. Oops, sorry for that. Let me just play it again. Okay, let me go to the previous slide. Okay, so we go to our cold spa. So when we say cold spa, it stands for first the character. So what is the character? Is the pain sharp, dull? Okay, or what is the feeling? Is he feeling bloated, full or bloated? Okay, the patient might say this discomfort, so that's the cold spa. And then for the onset, when did it happen, if ever there is pain? Okay, so for example 4 days ago, 5 days ago. And then location, you use your quadrants and your regions to locate the specific part of pain. Here in this corner or in this side, you could see the areas and the possible diagnosis if your patient would be referring to that pain location. Okay, so we're done with the location. Next, with the cold spa is D, which is your duration. Okay, so does it last for 1 minute, 2 minutes, or 5 hours? And what after the duration, you could also say the severity. Okay, so from the scale of 1 to 10, 10 being the most painful, what is the most, how could you grade the pain scale? Okay, and then for the pattern, you could ask your patient what does make it worse or better. So you could ask him, does positioning or change positioning make it better? Does eating food make it better? So by that, you could address it. Okay, and for the A, your associated factors. The questions you may ask here is, what are the other symptoms aside from the pain are you experiencing? So does it affect your ADLs or your appetite? So usually the patient could say here na, yes, after that severe abdominal pain, I could feel nauseated at night, and sometimes I get sweaty, cold sweats while experiencing this factor. So you also take note of the associating factors. So don't forget to do your cold spa if ever there is abdominal pain. Okay, but if not, then you're good to go. And here is the diagram of what pain could the patient experience. So for here, our right hypochondriac area or region, you have either problem with your gallbladder, having gallstones. For your stomach, usually it has ulcerations. A part of your pancreas is also here, so you could consider pancreatitis. For your epigastric area, either it has stomach ulcer, heartburn, indigestion. It may also cause pancreatitis, gallstone, epigastric hernia. So don't rely on the patient's claim that he or she has a pain here and you could diagnose it with this diagnosis. We have to collaborate first, and we have to do further extensive tests so that we could confirm for this test. But the probability of your patient having this pain could lead to these symptoms or disorders or diagnosis. So we have it here. I'll just let you have it screenshot or viewed. Okay, the link or the image link is here on the bottom. So let's just go with the next one. Okay, so we also will describe or ask for the patient's past history. So this one, we have previous abdominal surgeries, traumas, or injuries. During initial interview, you might not be able to see this, but while you are assessing, the patient might, I've been in a car accident before, so I have this operation in me. So by that, you could assess further after even you're doing your objective data gathering. So the patient might forget that traumatic incident, but later on you could ask, because every scar has its own story. That's what some quotes say. So there's a story behind each scar. You could ask them what happened to that. Okay, so here you could see the types of incision. I won't be discussing more on that, but you could just view it for your good to know. Okay, usually those are the scars done during surgery, and those are the implications. Okay, so are there previous abdominal pain and treatment? For example, is he or she using liniment for abdominal pain? Does it relieve? Is it effective? You could ask it like that. Any results for laboratory work? So you could ask for results for EGD or esophagogastroduodenoscopy visualization, or colonoscopy. That's the visualization of the colon. Okay, and then either you could ask for abdominal, whole abdominal ultrasound, whole abdominal X-ray, or whole abdominal CT scan if the patient has history for that. Okay, next slide would be the family history. Okay, so here are the parts of your digestive system in the lower part of your digestive tract. Okay, so has the patient or your client has history of any form of cancer involving your digestive system? Okay, so for example, your client has familial history of gastric or stomach cancer. You may indicate that. For example, your patient's family member had history of hepatic cancer or cancer of the liver. You could also say it in that. If ever your large intestine has the client's large intestine has cancer, we usually call it colonic CA or colon cancer. Okay, so for a male, cancer of the prostate is called prostatic CA or cancer. For female, the ovaries, it's within the abdominal area, diba? The ovaries of the patient having cancer in that area could be called ovarian cancer, and cancer of the uterus is called uterine cancer. So you could ask for those data. Okay, so also ask for abdominal pain. Were there any appendicitis, colitis, bleeding, or hemorrhoid? Okay, and this is also an important question. Excuse me for that. Okay, so 2 and 3 are just related because family lifestyle indicates that family member having the same history or having the same food habits or lifestyle could develop also lifestyle diseases or familial history because of that. So ask also who is cooking for the family and what type of diet he or she is in. Okay. For the lifestyle and health practices, this is also for the subjective data. We ask for smoking amount because smoking could cause gastric irritation and further stress in your gastrointestinal system. Alcohol use could lead to liver failure. That's why we ask for these two. Specific questions could be asked: how many? For smoking, how many sticks, and for how long? You usually ask these two questions. Okay, so the patient would be claiming, I've been a smoker, sir, how many sticks per day, and then for how long? The client may be saying that I've been smoking since 15 years ago. So we could cut. Resuming in 3, 2, 1, action. So here you could ask him or her how long he cut. Resuming in 3, 2, 1. So here you could ask your client for how long he or she had been drinking and smoking. Okay, it is also important for us to ask the food and drink for the past 24 hours. This may indicate your stool consistency and amount and color. Usually, eating too much dark colored foods or chocolate could change your stool color, especially in dengue patients. Diba? Usually, they would be asked not to eat dark colored food because it may be mistakenly indicated or diagnosed with having blood in the stool. That's why we ask for the food intake for the past 24 hours. We also ask if he or she had intake of milk because your patient might be lacto intolerant. That's why it was causing his diarrhea or her diarrhea. Okay. Moving on to your next, you use your antacid use. How much antacids does he use? Is the patient taking any proton pump inhibitor or protection for the gastric lining against ulceration or acidity? So you would be also asking that. Okay, so any medications, further explanation could be used. Remember that your abdominal assessment is not only limited for your GI, it also includes your reproductive and genitourinary, the elimination, and also your lymphatic or your immune system. So any medications that is related to either your reproductive health, genitourinary, and limbic system, we would be asking it as well. So for the fluid intake, okay, you could see it here in the picture. Ask the patient if he or she has adequate amount of fluid intake. You could ask your patient, ma'am or sir, how many glasses of water are you able to consume in a day? If ever he or she could not quantify the number of glasses that he or she is taking in, you could ask, in this mineral bottle water, which is a 1.5 liters, what level can you consume within the day? Then you could do your basis there. Okay, so we could also ask the exercise amount. Sir, why is exercise important for patients, assessing patients with abdominal problem or lifestyle? Okay, so this may be in two parts. As I have said earlier on the previous video, exercise could promote peristalsis or the normal movement of our bowels. Okay, so usually we see it in post-operative patients. They will ask the patient after procedure that if he or she had already passed flatulence. Kasi after that, they encourage movement furthermore so that the bowel movement would return. Okay, so this one also we would ask, what kind of exercises do you do? Because some of the patients may complain of having abdominal pain, but it is secondary to the exercises that they do. Sometimes they do strenuous exercises like planking, sit-ups, and then they suddenly experience muscle strain on their abdominal area. Usually those are secondary to the exercises or the activities that they do, so you could take note of that. Okay, that's why cold SPY is important on your assessment so that you could eliminate the factors that may be contributing to the pain. Okay, so number 8, you could ask for the causes of stress in life and the effect on eating and elimination patterns. So stress could affect your psychological behavior that may lead to decrease or increase in eating, or sometimes constipation or diarrhea. So ask for the stress of the patient, and as well as for the actions of the abdominal pain or any problems with it. Okay, so we're already done with the lifestyle. We'll be moving to the next, which is gathering objective data. And now let's continue with a gathering of objective data. So let's go with the steps in the checklist for gathering. Okay, so first, let's gather the things that we need. So we need a pillow. So for what purpose is a pillow? This would support you if ever you would be assessing or letting your patient lie on his side. That's the support, sir. And next, there would be your towels. Extra towels could be used as drapes if ever your patient is having body parts that are exposed, especially for female. You could use this one to cover their breast area so that it won't be exposed and to provide privacy as well. You could be using our marking pen if ever there is enlargement of an organ, or you want to mark specific measurements from point A to point B, we would be using our marker pen, and as well as your centimeter ruler, which can be used to measure the distance in between specific organs. Or if you want to make a rough estimate of the organ that you would be assessing or palpating, you could do so with your centimeter ruler. And then last but not the least, your stethoscope used for auscultation. Okay. Next would be the assessment scale. You could explain the procedure to the patient. So we see the nurse explaining the procedure and ask the client to put on the gown. Okay. Next one, we inspect the color, vascularity, stray, scars, and lesions of your patient. Okay, so we see here in the first set of pictures, we have here the vascularity. When we say vascularity, those are veins that are protruding. So here in this side, you see vascularity that is really prominent or seen because of working out. And here, I don't know if you could see that much, but there are vascularities, the green, semi-translucent green on the slide, because of ascites or fluid buildup in the abdominal area, therefore letting or visualizing the nearby veins to be seen. Okay. Next one is stray. When you say stray, these are markings. Usually they could be defined as either your stretch marks, okay, or linea negra, what they call here. This is the discoloration, especially when a pregnant woman is nearing her trimester or due date. Usually that is the blackish discoloration in the middle, and on the sides, those are your strays or stretch marks. Okay, next one, as I have said earlier, we have also your scars. We say that scars tell a story. So we have the transverse, paramedial scar. You have your lateral scars here. So you could inspect that. Also, we would ask for lesions. These are wounds in specific parts of your abdomen. So note for those as well. Okay. The normal for the skin color is usually they would be telling sorry cut resume in 3, 2, 1 action. So the normal color for the skin would be a little bit lighter in complexion because your abdominal area is not always exposed rather than your extremities. So you may say that the patient's color is consistent but slightly lighter due to the fact that it is hidden and not exposed. For the vascularity, the normal for it is usually veins are not seen. Okay, and for the stray, it's normally seen, especially if the patient had already gave birth or has lost weight. Usually it's normally seen. And scars are normal if he or she had undergone procedures or operations that you have taken within the health history. For lesions, you may ask what caused the lesions, if there is, but normally no lesions must be found on the abdominal area. Okay. Next one is inspect the umbilicus. Note for color. Okay, so what will we note for? The color, location, contour. Okay, so how will we say that? Upon inspecting the umbilicus, the color is even with the abdomen, so it matches the color around. Sometimes there is a little bit of darkening, but it's normal. Just make sure that it's not red. Okay, and then the location, it's midline at the lateral line. Okay, so usually it's laterally placed. And for the contour, you may say that it may be inverted. When we say inverted, that's the normal. Usually this is the common, what I mean, this is the inverted, so it's not seen, it's inside or tucked in or recessed. Or sometimes Usually it's inverted or recessed. That's the normal one. Or sometimes it's protruding, like this one here. Instead of it's the umbilicus tucked in, it's protruded outward. But make sure that it's not protruding more than 0.5 cm, because protruding more than 0.5 cm may indicate hernia or herniation. Parang mataas, there is a big pressure on your umbilical area pushing the umbilicus outward more than 0.5 cm. Okay, then for number 3, inspect the contour of the abdomen. So we have different kinds of contour. Let's go to letter A, which is the flat. So basically its contour is flat. We have also the scaffold. Okay, this is sometimes abnormal depending on the depth here, but usually it goes here and then a little bit of depression and then goes up. There's a depression in the middle. We could say that that's for letter B. We could say that the abdomen is rounded. Okay, this one is you could let your patient place his hand on the side, but for better visualization, you could ask the patient to raise his or her hand so that you could visualize further the contour of the abdomen, and make sure that the foot is not flexed and just lying straight. Okay, so it could be rounded. So this is circle, it follows the contour of a circle, and this is distended. Sir, so what's the difference between the rounded and the distended? So rounded, it just follows this pattern. Distended has more elevation, or what do you call this, has more mass over the usually rounded abdominal area. Okay, so this one, distended, is usually abnormal and scaffold is usually abnormal. Okay, so why is this abnormal? Usually these are found in super obese patients, diba? The layer of fat protrudes over. Okay, and for the depressed, sometimes this one is caused by malnutrition. Usually patients with having nutritional problems would have this scaffold, but I'm not saying that all with this physique are abnormal. There are times that they are abnormal and sometimes normal depending on the build of the patient. Okay, so further evaluation was we needed. So these are the 4 types or contour of the abdomen. First, we have your flat. Second, you have your scaffold, rounded, and last but not the least, your distended or your protuberant abdomen. Okay, so you could inspect this from the side, right side of the patient. You visualize it on what type of contour. You could also go to the foot part and visualize the abdomen contour of your patient. Okay, so here we inspect also for the symmetry of the abdomen. Okay, so try to view it from different angles. The normal finding for it, the abdominal is symmetrical bilaterally from the costal margin to the iliac crest. Okay, so usually costal margin, yung dito sa rib area natin, diba? There is an intercostal space. They are equal from the costal space and from your iliac crest. So iliac crest is here, diba? Usually in the bones, the hips, that's the iliac crest. The measurement from here and here is equal, so that you could say it's symmetrical by viewing it on the foot part. And medially, it's symmetrical in appearance. Okay, the umbilicus is centered, so you just use your umbilicus as a reference for your midline. Okay, so abnormal findings would be asymmetry. It may be caused by tumor, okay, bowel obstruction, or organomegaly. So usually for abnormal symmetry, you could see the patient having an abdomen bigger on this side and then abnormally displaced while lying flat. Okay, so make sure that your patient is lying flat on bed when doing so. So this one is abnormal. There's slight deviation on the patient's right side of the abdomen rather than the left side. you use this one as your margin. So that's why the book is asking us to view it from different angles just to see the symmetry of the abdomen. Okay, go to the next one. Okay, so we inspect the abdominal movement. So when the patient is breathing in and breathing out, usually there is the normal finding for it is there is a rise and fall. Okay, so when the patient inhales, usually the stomach depresses, and when the patient inhales, the stomach relaxes when he breathes out. So there's movement of the abdominal area. Note your respiratory movement, as I have said earlier as well. Note for your aortic pulsation. Okay, so when we say aortic pulsation, your aorta is around here. For people who have thin complexion, usually you would be seeing the bounding pulses, the up and down movement on that area. Okay. Also note for any peristaltic wave, especially if your patient has hyperactive bowel. Usually there's a small waving on the abdominal area. You could observe it. Okay. So just describe it during your health assessment or your abdominal assessment. Okay, so for the normal movement, you could say that the patient has movement of the abdomen upon inhalation and exhalation. I could upon assessment or inspection, aortic pulsations is seen, or you could say if it's not seen, it's not visible, and there is also presence of peristaltic wave. Okay, you could say it in the checklist. Okay, next we go to the auscultate part. So we're done with the auscultating, the inspection part. So in the pattern of assessing the abdomen, okay, let me just be clear. For abdomen, we follow the sorry, my bad. Let me just for the usual assessment, we follow the format of IPAA, which is inspection, percussion, palpation, and auscultation. But for the abdomen, we would not be following that pattern. We do the pattern of inspection, auscultation, percussion, and palpation. Sir, why do we have to follow this one? Because we don't want to elicit pain and do stimuli to the organs. That's why we do auscultation first. Kasi if you auscultated your stomach or your bowels, once stimulation is triggered with that, it might cause of hyperactivity to the area, or if ever there is pain, once it triggered the pain during percussion or palpation, the patient might not cooperate due to the factor that is hindering him or her to participate due to pain. Okay, and the breathing would be abnormal kasi since the patient is in pain, your respiratory rate is high, and sometimes the patient would be gagging since there is pain already. So participation is limited if you would be doing the most stimulus parts. So we start first with the less triggering, which is the inspection, followed by your auscultation, next with your percussion, usually light percussion, and then palpation. You have your light and deep palpation. Okay, so just remember that we follow the format of inspection, auscultation, percussion, and palpation when it comes to abdomen, not following your IPAA. Let's go with your auscultation. So next, step number 6 is auscultate bowel sounds for diaphragm. Okay, so note the intensity, the pitch, the frequency. So usually we auscultate it by quadrants. Sir, where will we start? So you could start with the right lower quadrant of your patient. You could compare it, then start with the other side. Okay, so start with right lower, and then right upper, and then go to left upper, and then left lower. Okay, you may be asking the question, sir, why? Because when we done the lung auscultation, we do it bilaterally. So why in the abdominal area, why do we have to do it one side at a time? So we do it one side at a time because okay, sorry for me going Tagalog mode. We do it one side at a time because there is no equal organ on the left side, except if you would like to do it for the kidneys and specific quadrants that would be requiring you to do it bilaterally. But for initial Auscultation, you do it by quadrants, one side first and then followed by the next side. Okay, so what is the normal findings? There is a series of soft clicks that would be heard, or gargles. Usually the rate for those clicks would be 5 to 30 clicks or gargles per minute. Okay, so you could hear also prolonged gargles. It may be heard on an empty stomach, especially when the patient is hungry. Diba? You hear it in animation, yung growling stomach. It means that a patient is hungry, so it's just normal as well. Okay, so that is your bowel sounds. So absence of bowel sounds within 5 minutes of assessment would be notifying that there is no bowel sounds. Hypoactive means there's decrease or least activity, that you would be getting 5 gargles or clicks in 1 minute. Okay, and then your active would be, you would be having 5 to 30 clicks or gargle sounds in a minute. So that's your normal active. Let's just say it's normal active, normal. This is your normal range. This is your decreased. And then your hyperactive would be more than 30 clicks or gargles per minute when you're auscultating your quadrants. Okay, sir, so how long will we auscultate or place the stethoscope over that quadrant? So some references say that you could do it for 15 minutes, but if ever you are not appreciating the bowel sounds, you could do a full minute or up to 5 minutes if you really want to determine for that quadrant to have bowel sounds or not. Okay, so we go to auscultating. After auscultating the quadrants, diba? Step 6 was just for the quadrants of the abdomen. Now we're going to define places for the abdomen. This is what I'm telling you earlier, that you could do bilateral assessment in this part. Okay, so we auscultate for vascular sounds. And what part of the stethoscope are we using? We would be using the bell. If you're previously, I haven't emphasized, but if you're going to just auscultate for bowel sounds, you use the diaphragm or the large portion of your stethoscope. And then when you're going to auscultate for vascular sounds, you use the bell of the stethoscope or the back part of the stethoscope. So first, we auscultate for vascular sounds and then friction rubs. Okay, so first, you could do it in a pattern that is upper to lower. You do it number 1. Start with your liver or your hepatic friction rub, and then followed by your splenic friction rub. This is side to side. Okay, and then you could go in the midline, which is your aorta. Okay, you could also check both of your renal arteries, and then your check for any venous hump. And then you could do both of your iliac arteries. You compare it to both sides, checking if the pulsation or there is any bruise. So that's what we're looking for. If there is bruise, 9 and 10. You could go also to your femoral artery, but it's beyond the quadrants. But for further checking for circulation, you could do so 9 and 10. Okay, so what are the normal findings after doing the motions of your stethoscope? You could say that there is no friction rub on both of your liver and spleen. So you may say that upon doing the auscultation for vascular sounds and friction rub, there is no noted friction rub over the spleen and liver. There are no bruise on the arteries, which is the aortic, which is on the aorta, renal arteries, both of the iliac arteries, and both of the femoral arteries. So basically, that's what you would do for this step. Okay, so we're already done with the auscultation part for your objective data gathering. Let's go now to the percussion part. So when we're going to do percussion, remember this is the hand position. Your dominant hand would be the one to percuss, and your non-dominant hand would be the one that would be buffering the impact to the part of the patient. Okay, so how are we going to do our abdominal percussion. So I have here a diagram. So we start here at the base of the liver, going to the liver borders itself. Okay, 1, 2, 3. You're trying to locate the liver, and next your number 4 would be your spleen. 5 would be also your spleen and a little bit of the anatomy of the stomach. Okay, 6 would be your stomach and a little bit part of the small intestine. Okay, number 7 would be your descending colon or descending part of your large intestine. Okay, and then number 8 could be also the part of your large intestine. Number 9 could include your small intestine and the bladder, also with number 10, the other side. Number 9, some parts of your large intestine. And last but not the least would be the upper part of your large colon, which is the end of the transcending colon and the start of the transverse colon. Okay, so that's your sequencing on how you would be percussing your abdominal area. Okay, so a little bit of review. Let me do a pen and paper. So this is your pen and paper illustration. So this is your rib cage or your intercostal space, end of your intercostal margin. Your liver would be located here. Okay, your spleen would be here because your stomach is lined around here. Okay, the 4 and 5. Okay, so this one would be going to 4 to number 5. You would be able to assess the descending part of your large intestine. If you're going to the number 6, you would be able to percuss your umbilical area. Okay, could do some of the umbilical area and some parts of the small intestine. For number 7, the descending colon. Okay, you could also hit the kidneys if you're lucky enough to percuss it. Okay, and this one is your bladder. You may able to percuss your bladder here. Here you could locate the ascending part of the colon. Okay, on this part, and the intestines would be in the middle. Okay, so that's the organs that would be palpated during the quadrants. Okay, so after doing so, you've percussed already the liver, you've percussed already the spleen, which is here on number 4. What you're going to do is I'm going to specify on how you would be doing your scratch test. Okay, so when we say scratch test, it is starting on your number 1 position in percussion. Okay, you would be, instead of percussing it, you would be doing scratches. So for example, here is your finger. Okay, and you would be doing scratching motion with your stethoscope placed here. Okay, let me just change the ink color. Your stethoscope would be placed here in the just below the sternal area. Okay, so this test say that upon scratching and moving your finger upward, so you're doing a scratching motion upward, okay, you would be able to locate your liver. And since the sound is conducted better in solid than in air, so we all know that the liver is a big chunk of organ in the body, you would be hearing sounds more when the scratching reach on the borderline of your what they call this, your liver. Okay, so for example, you've been doing the scratch test, you moved up here, you started here, you could take your marker, place your marker here and mark this as your start or of the base of the liver. Okay, you mark it here, you could say it's the base. You could just put a line or pentel pen to demarcate. Okay, and then continue your scratching. Oops, sorry, let me just go back. Okay, oops. Okay, so continue scratching until you know that the sounds is hard, or the sounds are loud, I mean, upon solid area. Continue until the sound goes softer or dim or dull. And then where the area that the sound gets dull, you mark it. That would be the end of your anatomy of your liver, the upper part. Okay, so this is your base and this is your superior portion. Okay, so you measure this area, and the normal for it at mid-clavicular line is at least 6 to 12 cm. Okay, so that's the liver span. You call the start from the base to the superior area the liver span. It's the extension on how high the liver is by doing the scratch test. Okay, so we're going to do our scratch test. So how we're going to do our scratch test? Okay, you're positioned at the right side of your patient like this nurse is doing. You put your stethoscope with the diaphragm pointed at just at the base of the sternal area. So this is your sternum. Your stethoscope would be here, and with your finger you would be doing a scratch instead of a percussion. So for example, this is the hand. On your position 1 where you start your percussion, you would be starting to scratch. Okay, so you would be scratching here in a scratching motion, and then locate where the sound gets loud. When the sound gets loud through your auscultation, you mark that point where the sound has significantly increased or got louder. Continue on your scratching until your scratch, the sound of the scratch becomes slow or soft. Then mark that point. Okay, so this one would be your inferior point, meaning the lower portion, and this would be your superior point. Okay, you get your ruler and measure this distance, and that would be your liver span. Okay, the normal liver span would be 6 to 12 centimeters according to the scratch test, but this test is debatable. They would just suggest ultrasonography for further visualization and measurement, but if you want to do a rough estimate on the liver span, you could do it like so, using the liver scratch test. Okay, let's go to the next skill, which is the blunt percussion for the liver and kidney. Okay, so sir, how would we do it? You ask your patient to sit down, the back facing you as a nurse. For example, this is your patient. He or she is facing forward, and you as a nurse would be here at the back. Okay. What you're going to do is with your non-dominant hand, you're going to locate your kidneys in the inferior side. Or first, let's just locate first your liver at your back portion or in the patient's back. What you're going to do is what this illustration is showing. With your non-dominant hand protecting the organ, once you have palpated it, give the patient a blunt tap or thud at the back. Don't use all of your might in doing this procedure because it might inflict great pain. Just do a gentle thud on top of your non-dominant hand, and ask the patient if he or she is feeling any pain or tenderness while doing the procedure. So once you've located, for example, this is your liver, this is the location of your liver. Okay, you put your hand like so over that area and then do a thud. Ask the patient, is there any pain, and try to see if there's any resonance with your non-dominant hand. Okay, if the patient does not complain, you move on to your kidneys. Locate your kidneys since it's bilaterally located in both sides. Okay, so for example, these are the kidneys of the patient. Okay, place your non-dominant hand over one kidney, do the thud, and then transfer to the other side. Okay, so the normal findings with this would be no pain and no tenderness upon doing this blunt percussion. So just me to emphasize more, this is just blunt percussion, so don't use excessive force in doing this test. Moving on with the next, we're done already with the percussion. We're going to the palpation portion. Okay, so for the palpation, what are we going to do? So number 13 step would be doing light palpation. So remember now, step number 13 is light. Step number 14 would be your deep palpation. So how would we do that? So basically, we are going to do palpation over the 4 quadrants again. So here in the illustration here in the right side or right corner, you're going to do light palpation over your right upper quadrant, then right lower or left upper and left lower. So observe for pain, for tenderness, okay, or for guarding. So normal findings during light palpation is there is no tenderness, abdomen is noted soft, and there's no guarding. Okay, after doing your light palpation, so check, let's this is already done. We're going to do step number 14, which is performing deep palpation or doing non-tenderness. So how are we going to do deep palpation? So there is a technique called bimanual palpation. This is where you're going to use your dominant hand assisted by your non-dominant hand in giving or exerting additional effort. Again, do this with careful, not full force, with guided force only to the abdominal area of the patient. Okay, so go on or go over the quadrants if you like. Okay, you could start here and the right lower. Okay, note for any tenderness or masses during deep palpation. Normal findings, the patient or your client might complain or might state a little bit of tenderness since you're doing it with a little bit more of force. So it's a little bit okay for tenderness over the xiphoid aorta, the cecum, the sigmoid colon, and the ovaries for females. Okay, the next one would be palpating your umbilicus, step number 15. So your umbilical area, if we are going to divide this in quadrants, this is the navel. Okay, all you have to do is you have to palpate in a circular motion. You could start it at the center and around the umbilical area. Note for any tenderness, pain. Okay, the normal findings for that, the umbilical area is non-tender and there is no guarding upon palpation of it. Okay, the next one would be palpating the aorta. So how would we palpate the aorta? There are 2 methods in palpating it. You could do 2-hand palpation of it, trying to locate it, but let me give you a warning or advice. Okay, so when palpating the aorta, make sure that your patient has no comorbidities, because if your patient has comorbidities or has history of having hypertension for a prolonged period of time, there might be a case of having aortic aneurysm. Okay, so what is aortic aneurysm? I have discussed it before during the normal discussion. So especially in patients with comorbidities, okay, so hypertension, usually this is the case, and elderly patients, kasi they have most likely the risk to develop aortic aneurysm. The aorta elasticity becomes lessened, or the walls of the aortic region is not that good anymore. Therefore, it might become bulged or become swollen, and narrowing blood flow on that area would be heard, especially if while doing your auscultation, you would be hearing bruit in the aortic area. So just be careful in doing this palpation, kasi it might trigger your rupture of your aneurysm if it's present. Okay, so how you're going to do it? You can do it lightly with 2 hands, locating your aorta. Okay, so the normal findings for palpation of aorta is it's non-tender, and there is no pain upon palpating your aorta. Okay, so that's just a thing to remember in palpation of your abdomen, especially your aorta. Okay, next we go to palpation of the liver. Okay, so same is true in doing palpation. You could do first light palpation over the liver area. Okay, for example, this is the liver. You do palpation over it. Note for consistency and tenderness. The normal findings for this is there is no tenderness. And basically, it's non-palpable originally. You could not palpate it directly kasi it's embedded in the layers beyond the muscles. So you could not palpate it easily. Especially if the patient is obese, you would be having a hard time in palpating it. Okay, so after the liver, you would be palpating your spleen. This is the stomach. This is the stomach and this is your spleen. So you can do palpation by two hands. Your dominant hand would be over the patient, and assisting on the back of the patient would be your non-dominant hand, pushing it out upwards for you to be able to palpate it better. Okay, so palpate it. Note for consistency and tenderness. So the normal findings is there is no masses noted upon palpation, and there is no tenderness or pain while doing it. Okay, so next one would be palpating your kidneys. Okay, so this one is number 17, palpating your liver. This one is number 18, palpating your spleen. And this one would be your number 19, which is palpating your kidneys. So your kidneys are located here. Palpate on both sides. Okay, so remember, it's kidneys with an S. So palpate both left and right of the patient, or right or left of the patient. Okay, for number 20, you would be palpating your urinary bladder. So where is the urinary bladder located? It's in your hypogastric area. So palpate it. Normal findings for this one. Among 17, 18, and 19, those organs are not palpable. But for the urinary bladder, especially if your patient is not yet able to void or is holding his or her urine because of the examination, you might feel a little bit of distension and it would be palpable. So out of the 4 organs, your urinary bladder is the only one that you could palpate. Okay, so upon palpation, it might be a little bit tender or discomfortable, especially if in full bladder, because it might urge the patient to urinate. But normally, there is no pain and tenderness during palpation of your urinary bladder. Okay, let's move on to the next one. Here are the special skills. Okay, so you might be asking, sir, will we do this skill? Okay, so the answer is no, if your patient has no ascites. Okay. Okay, so what is ascites? Once again, it's just the accumulation of large amount of fluid in your abdomen. Okay, so when we check for ascites, okay, this is just for learning purposes, but in the return demonstration, you would be saying that I would not be performing number 21 to number 23 because my patient is not my patient has no ascites or buildup of fluid in the abdomen. So basically, that's what you're going to say in the return demonstration. But for learning purposes, I would be discussing this. If your patient has ascites, what you're going to do is, usually it's visible because the tummy of the patient is really protruding or enlarged. What you're going to do is, upon palpation, the palpation motion would be from outer to inner on both sides. So you do outer to inner on both sides first, locate or estimate the fluid amount by doing so, or the extent of the fluid. Okay, usually the patient, let me just draw something here. Okay, usually the patient who has ascites, for example, this is the stomach and here is the foot. Okay, the upper portion of usually the upper portion of the stomach would be filled with air, and the lower part would be filled with fluid. This one is the fluid that escaped from the system, that part or just hanged out in their abdominal area. So usually it's filled with air. So if you're going to do percussion over the upper part, it would be tympanic, meaning it has a drum-like sound because of air accumulation on it. And then when you go down, when you percuss going down, it would have dull sound because of the fluid presence in the compartment or the thoracic, not thoracic, on the abdominal cavity. Okay, so this is what I mean with that in our diagram number 2. Here is diagram number 2. You ask your patient to turn to one side. In this case, this is the spine of the patient. The patient is turning towards his left side. Okay, so when the patient turns to the left side, you see that the air that is usually from above or positioned above would be displaced towards the side which is facing upright. Okay, so from the fluid here on the center of the abdomen while laying flat, it would be going to the right side of the patient. Okay, so the dullness would be changing. So the shift there is called shift in dullness. Okay, so the area where the dullness would be present would be changed. So therefore, this would prove that while doing position change, the dullness would be shifting towards one side to another. Okay, here in the illustration for number 3, this one is just performing the percussion technique. Now the patient is turned towards his left side. Okay, so this is the right side of the patient and he is turned to his left side. What the practitioner or the nurse is doing is he is trying to determine where the part of dullness starts and ends. Okay, so he would be doing percussion from one side to another, determining where the dullness would be percussed. Okay, so that's how do you do the shifting of dullness for people with ascites or fluid in the abdomen. So this one would be more specified if the patient has larger than 1.5 liters of fluid accumulation in the abdominal area. Okay. The next special test, if with ascites, that you would be skipping as well, okay, would be performing the fluid wave test. Okay, so how would you do this? You ask your patient, sir or ma'am, could you put your hand, okay, this is the patient's hand, in the middle of your abdomen, applying a little bit of pressure. Okay, so we would be making like a border or a barrier in between. And then the nurse practitioner's hand, signified by the blue outlines, would be positioned at both sides. And one side, for example, this right hand, on the next illustration, number 2 illustration, on the right hand, I would be tapping gently the right side of the patient, the left side of the patient, what I mean with my right hand, I would be tapping it. Okay, so there's a movement or tapping. You would be seeing the hand of the patient moving as well. So that means there is fluid accumulation and the buoyancy of the liquid, or the presence of the liquid is here. It would create some waves going to the other side. So it feels like a jello wiggling around. You would be feeling it here at the nurse's left hand. So nurse's right hand, nurse's left hand. This is the patient's left side and this is the patient's right side. So when you stimulate or you do tapping, you would be feeling the shifting or movement of fluid in a wave, and you would be seeing the hand of the patient moving as well as you do this procedure. Therefore, saying that the patient is positive with fluid wave test if there is movement of fluid against the resting hands, especially if there is a large amount of fluid present in the abdominal area. Okay, so this is how you do the fluid wave test. You go to the number 3 test, which is the ballottement test. Sir, ballottement seems a little bit familiar for me. Yes, it's familiar for you because this is the fluid in the patellar area or your knee. This is just manipulation of the fluid in that area, specific area. So what you're going to do is you're going to fix your finger in a stiff position, And over the abdomen, for example, this is the abdomen of your patient and you're suspecting ascites, you try to manipulate the fluid, okay, by a motion of jabbing, and try to determine if there is free floating mass, or determine if there is, for example, this is the mass. You would be determining if this is a free floating mass or it's solid there over the fluid filled area. So this is the fluid filled area. I'll just be representing it with blue. Okay, and you try to do this procedure and try to manipulate the movement of fluid while assessing if there is any mass. Okay, so this procedure may be painful, but usually this is caused by your inflammatory process. But if the patient complains of pain, you immediately stop the procedure and do your cold spa. Okay, so let's be clear with that. Okay, so 23, this one is 23. So, sir, again, let me emphasize, 21 to 23 from your checklist would not be performed because if you have a normal abdominal findings without any fluid, you would be skipping the test. Sir, what will we do in the assessment or return demonstration? Just say that I would be skipping first what's the first test? I would be skipping the shifting dullness test. I would be skipping also the fluid wave test and also the ballottement test because there is no presence of abdominal fluid or ascites in my patient. So that's what you're going to say in the return demonstration. We'll go on with the next one, which is a series of special tests for appendicitis. So appendicitis. So a review again. What's your appendicitis? It's the small piece of tissue that is attached before the ascending colon. Usually, this one is inflamed or it's a part of the limbic system that may introduce or may respond because of infection. So usually, swelling is prominent with that. But if it's really inflamed or it has inflammation or infection, inflamed or infected, okay, we would be doing a series of tests. So the first test to test for appendicitis is the rebound test. Sir, it looks like a complicated test. Yes, it's a very complicated. It looks very complicated when you just read the text, but basically what you're going to do is you're going to instruct the patient to relax and tell him or her that you would be applying pressure over the part of the large intestine. So basically this is your appendix. Let me just change the color. This is your appendix. This is the part of your colon. This is your right lower quadrant. Okay, if you're going to divide it, oops, sorry, let me use the umbilical level as a reference. Right upper quadrant, left upper quadrant, left lower quadrant, and your right lower quadrant. Since your appendix is located at your right lower quadrant, what you're going to do is you press down on the part of the column in your right lower quadrant, and when you release it and the patient complains of pain, that is what you call your rebound tenderness. So you could say that upon releasing of the pressure on the right lower quadrant, the patient is positive for rebound tenderness because he or she complains when pressure is released from that right lower quadrant. So basically, when releasing and the patient would feel the pain, he or she is positive for rebound tenderness. Okay, so that's your first test, the rebound tenderness. The second test is the Rovsing sign. Okay, big words again. So what is the Rovsing sign? It looks intimidating when you're going to read it. So this one, it's elicited by palpating the left lower quadrant or the opposite quadrant. Okay, so let's make divisions again. This is your left upper quadrant and this is your left lower quadrant. So opposite would be your right lower quadrant. Okay, so basically this one, you would just be putting pressure. You just ask permission to the patient so that you won't get kicked or boxed by the patient if there would be pain. Just try to do it slowly and gentle as possible. So you would just be applying pressure with your non-dominant hand. You apply pressure over the opposite side, which is the left lower quadrant. If the patient would be complaining for pain, okay, so take note, if the patient would be complaining for pain on the right lower quadrant, by pressing your left lower quadrant, you may say that their patient is positive for the Rovsing sign. Okay, a little bit of review for the rebound tenderness. What is it? When you put pressure on the right lower quadrant, upon releasing, the patient would feel pressure. That's your positive rebound tenderness. For your Rovsing sign, you would be pressing the opposite side, which is the left lower quadrant. So upon releasing or pressing the left lower quadrant, the patient would complain of severe pain on your right lower quadrant. Therefore, he or she is subjected for a positive Rovsing sign. Okay, so that's a little bit of a tongue twister. Okay, let's go to the next test. This is not just a test, but for patients having acute appendicitis or pain due to acute appendicitis, the most painful area, for example, this is your appendix. Usually your appendix would be situated here, or I guess lower, but for illustration purposes, it would be here. The most painful part would be your McBurney's point. Okay, so this is sorry, let me just arrange my annotations. Okay, so this is the point between the navel and the right anterior superior iliac spine. That is a point where the most pain is elicited by pressure in acute appendicitis. So this is, I don't know why the nurse is holding it, but this is your McBurney's point. Okay, so it's between the navel, this is your navel, and your iliac spine. So let's locate the iliac spine. This is the iliac crest. This point, this is your navel and your iliac crest. This area is your McBurney's point. McBurney's point, the most painful area for acute appendicitis. Okay, so it might show up in a quiz, so just remember this one. Okay, let's move on to the next test. Okay, a little bit of review: the rebound tenderness, and we have the Rovsing sign. Next is the Psoas sign. All are tongue twisters, especially if you have braces. This one is the Psoas sign. So how will we evaluate for the Psoas sign, or how will we say that the patient is positive for the Psoas sign? Let your patient lay down on her left side lying position. Ask her initially to put both of her feet straight. So this is just step 1. So initially you ask her to lie on her left side. Okay, so when you already instructed your patient, okay, you could put your pillow here, so support. When you instructed your patient to lie on her or his left side, okay, what you're going to do is you are going to extend the hips and do extension of the hips and try to manipulate the right leg. Okay, so this is what is seen in the illustration. From both straight foot, one foot would be remaining straight. Okay, and you try to flex the hip area. Okay, so basically you're just moving the right leg of the patient towards yourself in this portion, and when you move it, the patient would be experiencing pain on his right lower quadrant, and for compensation, this initial straight leg would be flexing in compensation for the pain that is felt. So when the patient feels pain, and the other leg would be bending just to compensate for the change in position, that's the time that you could say that he or she is positive for Psoas sign. Okay, because extension of the hip or the leg will trigger the patient to change the position so that it would provide relief to the patient. So if ever there is pain and the other leg would react to the flexion, the extension of the right leg, then the patient is positive for Psoas sign. These tests are painful, especially for those with acute appendicitis. So do it with caution as always. Okay, so why does it hurt when the flexion of the the extension of the legs are elicited or done? Okay, so because the hip area houses the appendix. So stimulation of this one would trigger the pain, the sensory muscles for pain here. Therefore, telling your brain to react so that the pain would be relieved. Therefore, it tries instantly to flex your other leg for it to feel relieved. Okay, so that's how you do your Psoas sign. Okay, the next one would be the Obturator sign. Obturator means, there's a part of your femur which is called the obturator, and there is obturator muscles that surrounds that. Okay, so ask your patient to lie on his or her back, okay, like so, with feet both stretched. Try to passively raise the right leg and try to, so the leg is raised, the right leg is raised and flexed at the same time. Okay, and then you're going to try to rotate the hip internally. Okay, so basically the foot is initially facing here, later the foot would be moving here on this part, and your leg position would be like this. Okay, movement with this part would trigger pain for the patient, since the appendix is also here, and it would signal your patient that it's painful because of the sudden movement. So therefore, you could say that the patient is also positive for obturator sign when doing this specific test. Okay, so again, what are the tests? First is the rebound tenderness, the next is the Rovsing's sign, the next is the Psoas sign, and then the next one is the obturator sign. Okay, so last but not the least, this one is the hypersensitivity test. How could we say that the patient is positive for appendicitis? By the hypersensitivity test, what you're going to do is, on your right lower quadrant, you try to pinch or try to manipulate a skin fold over that area. If the patient would suddenly complain of severe pain on the right lower quadrant, severe, or parang in other terms or in our terms, it's like overreacting pain, but really it really hurts if your patient is experiencing this hypersensitivity pain due to appendicitis. It's really a bad thing or experience for them. So upon pinching the skin fold or trying to stimulating or lifting it, there would be sharp pain that would be experienced in the right lower quadrant. Okay, you could also do this test for hypersensitivity by gently dabbing a pin or a sterile needle over the area. So don't puncture the abdominal area, just try to jab. Okay, so it's like poking over the abdominal area with the pin. Okay, if the patient feels as well sudden pain over that area, it's because of hypersensitivity. Therefore, you could say that the patient is positive for hypersensitivity, and there is probability that he or she has appendicitis. Okay, so last but not the least, for our assessment skills, we have here our special test for cholecystitis. Okay, so cholecystitis, when we say cholecystitis, what organ is involved? It involves the gallbladder. What I have said before, it's the open and close quote na non-essential organ because it just stores bile. Okay, so how would we do the Murphy's sign or Murphy's test or Murphy's sign for cholecystitis? So ask the patient to exhale, and then with your hands as seen as the diagram. You place it below the costal space margin on the right side and at least in the mid-clavicular line. So this is your clavicle, for example, and this is your costal space, diba, yung rib cage. This is your sternum. This is your mid-clavicular line. Okay, so you place your hands on both sides, ask the patient to exhale, and then place both hands on the side and ask the patient to inhale suddenly. And if ever the patient would be if ever you feel that the patient would stop breathing for a brief amount of time and try to catch up with it, okay, because of the pain, sudden pain or sudden discomfort that he or she is feeling, therefore you could say that the patient is experiencing acute cholecystitis, and you could say also that the patient is positive for Murphy sign. Okay, so again, what would you do? First, ask the patient to exhale without your hands on the abdomen area, and then upon exhaling, you instruct your patient to please keep on exhaling slowly. You place your hand on the specific point, okay, and then try to let your patient inhale. If ever there is breathing interruption or catching in breath, it may indicate that the gallbladder is being palpated or enlarged due to descending upon inspiration. Therefore, you could say your patient has positive Murphy sign. Okay? And our favorite part of the assessment would be, first, the summary of all. First, formulate our nursing diagnosis. So, don't forget to wash your hands prior to and say goodbye to your patient. You formulate your collaborative problems, and last but not the least, if you have significant findings, make necessary referrals, especially to the people who are expert or specialist with the cases of abdomen. So with that, thank you very much, guys. Have a wonderful day. Sorry that this is uploaded a little bit late. I have technical problems, but hopefully, if there's a will, there's a way. God bless you all, and have a nice day again.